Welcome to Thoracic Ultrasound. My name is Matt Lyon. Let's begin. So our learning objectives are to define a systematic method for evaluating the thorax using ultrasound, to identify normal anatomic structures of the thorax using ultrasound, and to correlate ultrasound findings to pathology. Really, this is a lecture on how to read a chest ultrasound. Many people have probably not done thoracic ultrasound. Thoracic ultrasound is a relatively new ultrasound modality. It has been used for the last several years and its uses are expanding. We use it for a wide variety of diagnoses such as pneumothorax, pneumonia, interstitial edema, atelectasis, lung abscesses, lung cysts, and the list keeps going on after that. But why would you want to use ultrasound when you have a chest x-ray? Well, first off, ultrasound is portable, which means that it can be used in a wide variety of settings. It could be used in the ED at bedside, or it could be used out of the hospital in scenarios such as a disaster setting. Ultrasound is very good at eliminating differential diagnoses. So you usually start out with a large number of potential diagnoses in a patient that comes in with shortness of breath, and ultrasound can help eliminate these one by one, narrowing your differential. Ultrasound is more sensitive than the physical exam. It's actually more sensitive than your stethoscope, and it's probably as accurate as CT. So this is a really powerful clinical tool to use on our patients, especially when you combine it with other things such as your physical exam, x-rays, and those other modalities that you're typically using. So as we go through this lecture, we're going to talk about key concepts. First key concept we need to talk about is having a systematic process for evaluating the lung and the thorax. So the process is listed over here on the side, and we're going to go through each of these one by one. For a typical thorax ultrasound, we're going to start with our probe across the ribs. See here that we have our probes up and down across the ribs so that we can see each of the ribs in our ultrasound field. You can see the ribs here. This is a linear probe, so it has a flat face. And we can see the linear probe shows this rib as a bright line and shadowing behind it. The shadow is caused because this is a bone. If you use a different probe, you may not have as much shadowing. Then we're going to look deep to the rib, and the next line we see is right here, and this is the pleural line. Pleural line is always deep to the rib, and it's also always adjacent to the posterior portion of the rib. We can't see the posterior portion of the rib because of the shadowing, but we can see that this line is adherent to the posterior portion of the rib. Then we're going to look for movement of the pleura. This whole image is moving up and back or side to side with respirations. But if you look at the pleura itself, the pleura is sliding also. Here's a larger example. This is using a curvilinear abdominal probe, so it looks a little bit different, but we can see the rib and shadow. We see the pleural line, and we can see how that line is moving back and forth, back and forth. Notice that we took the gain. This is a typical gain. It's fairly bright, and we've turned it down. As you turn down the gain, this bright line, this echoic line that is the pleural line, becomes easier to see because it remains bright, whereas the rest of the surrounding tissue becomes darker. So you can see this movement very easy as you turn down the gain. What does this represent? Well, if we look over here at the CT scan of the thorax, we can see the lung, and we can see the chest wall, and both of those have a lining, the pleural lining. The thorax has the parietal pleura, and the lung has the visceral pleura. So that really this line that is we call the pleura is made up of two different tissues, the visceral and the parietal pleura. So as those two pleura move against one another, we see that as this motion, back and forth motion we see here. The next thing to look for is artifacts arising from the pleura. So if we look at the pleura, this is normal lung. We see the pleura sliding back and forth, and we really don't see anything back here. Nothing that's identifiable. It looks just like static. There's a couple little streaks or artifacts that are appearing, coming and going. These are normal. They're very minor, but we really don't identify anything back here. The next key concept is where to scan, and also the patient's position. This is really an important concept because where you find artifacts is dependent on the pathology present, but also helps you define the pathology. So for pneumothorax, we want to scan the anterior chest, we want the patient to be in a supine position. If we're looking for pleural effusion, we want the patient to be in a semi-erect position. We're looking for the costophrenic angle and looking for fluid. And if we're looking for interstitial edema, we need to scan the whole chest and we need to correlate that to body position. We also need to know what position the patient has been in before they presented for your scan. So let's start with some cases. 34-year-old male comes in, he has a history of AIDS, he has acute shortness of breath, he has no history of trauma, he has no fever or weakness, and he has left-sided chest pain. So as we look at this ultrasound image we have here, we have a curvilinear probe is placed across the ribs. We identify the ribs, they are here. Then we identify the pleura. The pleura is the bright line that's just deep to the rib. So here's the pleural line. And the next thing we do is look for movement of the pleura. So we look right here and we see is there any movement of the pleura. First things you have to ask is where's the probe? Well, we know the probe is across the ribs. We see the ribs in cross section. But where is it? It's in the anterior chest. This is where we're taking this image. And the patient is supine. What does this represent? Well, this is a pneumothorax. It did not have the sliding that we saw before. So as we looked before, we identified the rib. Here's the rib in shadow. Here's the pleura. And we looked and there's motion of the two pleura against one another because they're adherent as they are in the CT scan. The two pleura are one against each other, so as the lung slides due to inspiration and exhalation, we have sliding of the two pleura against each other in this sliding motion. In this case, we identified the ribs, we identified the pleura, but there was no sliding of the pleura. And that's because we're only able to see one of the pleura. In the pneumothorax here, we see that the pleura around the lung, the visceral pleura, is separated from the parietal pleura, which is part of the chest wall. So since ultrasound cannot image through an air interface, we can't see this visceral pleura or the deeper pleura. Therefore, we do not see sliding up here. We see a single line. This indicates that this is a pneumothorax. 40-year-old female comes in. She's got AIDS, acute dyspnea, no trauma, fever, weakness, left-sided chest pain. Very similar as before. Let's see if we can identify what's going on with this patient using our systematic approach. So we put our probe across the ribs. Here's our rib. We have shadow. We identify the ribs. We identify the pleura. Here's the pleura. And we look to see if it's moving. The pleura itself is very difficult to see because we're very deep. We don't have our image is not shallow. We have not decreased our depth. But there is sliding of the pleura. So this is not a pneumothorax, because we can see the two pleura sliding one against each other. And then we look for artifacts coming from the pleura. If you look here, there is something that we see deep to the pleura. What is it? The example we showed at the beginning, here's the rib, shadow, here's the pleura. We should see nothing behind the pleura. All right, this is normal lungs. It looks distinctly different than this, where we see these big streaks coming from the pleura and going off the screen. These vertical lines are called lung rockets. Some people call them B lines, but these indicate that there is fluid in the alveoli. So vertical lines starting at the pleura and going off the screen indicate fluid in the alveoli. This is in contrast to this. This is normal aerated lungs, and we don't see those vertical lines starting at the pleura and going off the screen. The number of these vertical lines or lung rockets is proportional to the amount of fluid present. So a single line coming from the pleura off the screen would be little fluid. This has many lines coming off the screen. This would be more fluid or a lot of fluid. For these to be true lung rockets indicating fluid in the alveoli, they must start at the pleura. They must go all the way off the screen. This is why the depth is increased to 13 centimeters. You can see that it goes off the screen. If you increased it to 16 centimeters, it would still go off the screen. And it must move with lung sliding. So they're moving because the two pleura are moving, just like we talked about before. That's how we know this is not a pneumothorax, because we can see the lungs. If we can see the lungs and we can see the fluid in the lungs, we know that there's not an air interface between the two pleura. Therefore, there's not a pneumothorax. You see the fluid in the alveoli with several clinical conditions. Cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, also known as ARDS. You can see it with pneumonia. You can also see it with pneumocystis, miliary TB, and CMV. But you really have to ask yourself, where's the probe and what was the patient position before arrival, because fluid will go to the dependent portion of the lungs. So if your patient came in ambulatory and you found the fluid in the bases and it was in both bases, that would tell you some information, as opposed to if the patient came in ambulatory and the fluid was only in the right upper chest. If the patient had been laying flat for 2 days, the fluid would be in the back, and as you came around towards the front of the chest, it would become less because it would be dependent towards the back, as opposed to the patient that came in ambulatory and had the same condition. Their bases would be the dependent portion, so it would be, as you're down lower in the back, there would be fluid, and as you move up the chest wall, either front or back, it would become less. Where the probe is and what the patient position is before arrival are very important. So this really gets into the 3 parts of clinical ultrasound. There's image acquisition. That's what we do when we place the probe on the chest. There's image interpretation. That's what we've been talking about with our systematic approach. And then there's clinical integration. That's how you integrate asking the patient questions about what position they were in, what other symptoms they have, what other comorbidities they have, and correlating that to your other ultrasound exams, such as the IVC and determining fluid status, or looking at the heart and determine their ejection fraction. So if we combined all of these things and we say a patient was ambulatory, they've had shortness of breath for the last several days, they have a history of congestive heart failure, we find fluid in their bases. Fluid in their bases is the same thing as lung rockets, as we have here. We find lung rockets in their bases, and as you move up their back, they're less intense or go away, which means that there's more fluid in the bases. As you move up the back, there's less fluid in the upper lobes of the lungs. That would be consistent with cardiogenic pulmonary edema, particularly if their IVC was full, meaning they had a high central venous pressure, and their EF was poor. If you have another patient that came in, and let's say they've undergone a trauma or they've had some reason to have ARDS, and you ultrasound them, they have fluid in every alveoli, all of their lungs. You look at their heart and their heart's beating normally. It's unlikely to be cardiogenic pulmonary edema. This would be more likely to be non-cardiogenic pulmonary edema, and that would be ARDS. If you're scanning a patient that comes in and they have shortness of breath, they're been having fever, and they have lung rockets or fluid in the alveoli only in the right upper chest, you suspect they have pneumonia. Fluid in the alveoli are surrounding the pneumonia. That's the inflammatory cells as they come to fight off the infection. They're causing lung rockets or fluid in the alveoli around the pneumonia. So if you find isolated lung rockets, you can think, well, does the clinical scenario indicate a pneumonia? Well, if it does, then that's probably a pneumonia. So we have to take our multiple exams, we have to integrate them into our differential diagnosis. So if we start off in the center, we have lung rockets, meaning they have fluid in their alveoli. This is at the bases, and as we move up their back, it gets less. We think, well, that sounds like a pulmonary pattern for congestive heart failure. What else would go with congestive heart failure? Elevated CVP. So we look at their IVC. Here's their IVC. It's very dilated. It's not collapsing with respiration. Therefore, their central venous pressure is high. What else would go with congestive heart failure? Well, a poor EF would. So here is a parasternal long axis. This is the left ventricle, and we can look at the ejection fraction, and it is very poor. So this appears to be somebody with dependent fluid in their lungs, an elevated central venous pressure, and a poor EF. If the history supports this, you would start thinking, what could this be? Clinical integration. There's a CT of the chest to go along with your lung ultrasound. And this is consistent with congestive heart failure. Here's another one. We have fluid in the lungs. In this case, this fluid is only on the right side of the chest. We look at their IVC. It is very flat. This means that their central venous pressure is low. That does not go along with congestive heart failure. Look at their EF. Their EF is very high. This is the left ventricle. You can look at the endocardial borders. The EF is very high. That would indicate that they have a very high cardiac output, a low central venous pressure, yet they have fluid in their lungs. It's only on the right side. If you were going to put this together, you would have to ask some questions. Here's a CT scan we have of the same thing. And you integrate that clinically, and this would be consistent with pneumonia. So let's go to another case. We have a 40-year-old female comes in. She has a history of AIDS. She has acute shortness of breath, no history of trauma. She has fever, weakness, and left-sided chest pain. So let's use our protocol. So this is a different probe than we've been using before. This is a phased array or a sector probe, and as such the ribs are very small on the image. So we put our probe across the ribs. Here's our rib. Here's our rib. There's very little shadowing because this probe is meant to get between the ribs and image behind the ribs. This is typically referred to as a cardiac probe because it images behind the ribs very well so you can see the heart. So we identified our ribs. We look for the pleura. The pleura is very difficult to see because it's very small, but we can see that it's sliding back and forth. We look for artifacts arising from the pleura. We do not see those big streaks or lung rockets as we did before, but we do see an image. This is actually the diaphragm. That's would be expected to be seen by this phased array or sector probe if you had slid far enough along the side, and you would image the liver and the diaphragm. But above the diaphragm, we should not be seeing anything. That should be air-filled lungs, yet we see this structure. So what is this structure? Again, here's the normal, all right, rib, pleura, sliding, nothing below the pleura. We should not see anything with normal aerated lungs. Yet in this case, we see something. This something is liver-like. Here is the liver, and it has black filled spaces, which are fluid-filled or blood-filled spaces. This is part of the portal system, portal vein system. And then we look at this area. This is very liver-like, similar texture, yet it is filled with white spaces. These white spaces are actually pus sliding in and out of the bronchioles. And this is a consolidated lung. This is pneumonia. So, as the lung fills with pus, it becomes consolidated, hence it is not filled with air anymore, and we can see it. As long as it touches one of the pleura, so if it touches the pleura of the lung, or the diaphragm, or the pericardium, we can see the pneumonia. And these areas inside of these bright white areas are air bronchograms, or this is where there's pus filling the bronchioles. It doesn't completely fill it, so it doesn't completely expel all the air, and you can see as they breathe, the pus is sliding up and back in the bronchioles. This is called hepatization of the lungs, and it is indicative of pneumonia. We can see the same thing here on the CT scan. We see the pus-filled lung, so it's not air-filled as this is up here. We can also see here's the bronchioles, and they have pus filling the bronchioles. You can see them here. So these white spaces on the lung ultrasound are the correlate of these black spaces, air-filled spaces, on the CT scan. So this is the CT of a pneumonia using ultrasound. Here's a larger example so you can see all the things I pointed out. This is the lung. You can see that it's pus-filled, so it's liver-like. Here's the bronchioles, and you can see the pus sliding in and out of the bronchioles. This is pneumonia. But you have to ask yourself, where's the probe? So wherever you locate this pneumonia is the lobe of the lung that has the pneumonia. But lung ultrasound is a little different than reading a chest x-ray. So if we look at the right chest, and we're using a chest x-ray, and we correlate that to lung anatomy, it's a little different than the way we normally talk about lungs. We usually talk about the right side as being the right upper lobe, the right middle lobe, and the right lower lobe. We start off here, you can see that the lower lobe, outlined in blue, takes up most of the back. So if you place your probe on the back and you find a pneumonia, it's in the lower lobe, even if it's fairly high on the chest. If you place your probe on the anterior chest and it's on the upper portion, it's the upper lobe. If you place it on the lower section, it's the middle lobe. And we can see that here. Here's if you place your probe on the upper portion of the anterior chest, it's the upper lobe. The lower portion of the anterior chest is the middle lobe. And if you place the probe on the back, it's the lower lobe. The left chest is very similar, except it does not have a middle lobe. So if you place your probe on the back of the chest, you have the lower lobe. If you place the probe on the anterior chest, it's the upper lobe. I generally refer to this as the anterior lobe, and the posterior lobe because it makes more sense anatomically than upper lobe and lower lobe. So let's go back to our cases. 34-year-old male, history of AIDS, acute shortness of breath, no trauma. He has fever and weakness, left-sided chest pain. Same case as before. We put our probe across the chest. We see our ribs in cross-section. We identify the pleura. We look at the pleura and we look to see it sliding, and we see it sliding back and forth. And then we look for artifacts below the pleura. We do see a little bit of an artifact here, but it is not those vertical stripes we talked about before, or lung rockets. We also want to look at the pleura, and we notice that this pleura is very irregular, and it looks like it has a pothole or a divot taking out, and it's fluid filled. What does that mean? Well, the pleura should be a nice, bright, smooth line, and it should not have artifacts below it, as we talked about before. In this case, we see that this pleura is very irregular and has a divot taken out. This is actually pathology. To be able to see this type of pathology that affects the pleura only, you must use a linear probe. So if you're using a phased array or an abdominal probe to do your lung ultrasound, you must switch to a linear probe or a flat face probe so that you can see these details. This is because the linear probe is higher resolution and is able to see these type of details due to the resolution. So this is actually a pulmonary infarct. All right, you see that with a pulmonary embolism. It's a pleural-based hypoechoic lesion, and it can be located in any lobe. Of course, a PE can go to any artery, so it can affect any lobe. This occurs because the artery is cut off, so this portion of the lung has died and collapsed. All right, so you have collapse of the lung, and it's filled in with fluid. So we see this divot out of the lung, and it looks like a pleural-based hypoechoic lesion. And this is lung collapse just distal to that. There are other things that can cause similar looking divots or irregularities in the pleura. Those would be TB as well as pleural-based cancers. TB looks a little bit different. It is a hypoechoic pleural-based lesion as we saw with the pulmonary infarct, but it generally has a different appearance to the lung below it. So if you look here, the lung does not look collapsed below it. This is actually a tuberculoma, and it's usually found in the upper lobes, and it does not mean that they have active TB. Another thing you might see every once in a while is artifacts arising from the pleura that have a diagonal instead of a vertical appearance. These are due to irregularities on the pleural surface, as we talked about before. However, these are not divots or pulmonary infarcts as we've seen in the last two examples. These are small little echogenic foci that are on the pleura itself, and because the ultrasound beam is formed using multiple angles with a linear probe, this is called multi-beam on some machines, the beam is striking this echogenic foci at various angles and causing this varied appearance. This is called the trident sign. Looks like an upside down trident. And this is due to echogenic foci on the pleura itself. There's several things that can cause this. It can be seen with miliary TB. It can also be seen with prior pleural inflammation. These do look like lung rockets and they can be confusing, but generally lung rockets are vertical lines that start at the pleura and go off the screen. These are at an angle and multiple, going to a single focus or point on the pleura. That's how you can tell the difference. So in conclusion, thoracic ultrasound can be used to identify multiple causes of shortness of breath. A systematic method for evaluating the thorax helps to identify pathology, avoid missing pathology, and helps to correlate to other clinical findings.